Good afternoon, everyone, and thank you very much for joining us for this symposium that is going to be special because it's talking and focusing on patient-centric. When patient is in the center, when we care for him in diabetic macular edema and RVO. And we're going, it was very nice, this event is sponsored by ABBVIE, and it was very nice that they complied, the organization complied to the standard of the meeting, which is controversies, debates and controversies. So hopefully we'll have a lot of very exciting discussion. And I'm moderating it together with my colleague, Professor Laurent Kodjikian. And where I don't have the... So I'm moderating it together with Professor Laurent Kodjikian, and we will have three interesting discussions. From pathophysiology to clinical practice, is what you see the same as what you get with Francine and Laurent. We'll have the second discussion debate if steroids should be considered as first line, and this will be debated between Patricia and Fang Lu. And then we will talk about persistent macular edema, and we will debate it between myself and Thibaud Mathis. So I look forward to a lot of exciting and interesting discussion for all of us. Please scan the QR code to access the application. I believe it is also the Slido application, and here you can both submit the polling questions, the polling responses and the questions. And for the questions, you are either invited to have them on the Slido application or come up to the microphones. Was it enough time? Oh, sorry. Actually, I want to go back. Oh. I try to go back, but it doesn't go back. Here, okay. Sorry, so just one more minute to slide, to scan the barcode. And without further ado, I will ask Professor Francine Behar-Cohen to tell us about the pathophysiology until clinical practice. Is there anything hidden? And for the for the no side, what you see is what you get. Francine.
Oh, it's not really a debate, but we are complimentary in giving this talk. So this one, okay, thank you, and good afternoon, everybody. Here are my disclosures. I just put this slide, which is actually the labeling of glial Müller cells in the retina, and you see here they are very activated, and without this labeling, would never have been able to detect anything. So, you know, there are things that are hidden. So, of course, when there is edema, it's obvious that we have inflammation, you have signs of leakage, and you have plenty of signs that it's obvious we don't need to ask the question, is there inflammation here? But there is another type of inflammation, which is called neuroinflammation. And neuroinflammation is the activation of the cells that are present in the retina, and they are glial cells. So they are astrocytes, Müller cells, and microglial cells. Each time there is any type of stress, they are activated to allow restoration of homeostasis. But in case there is too much of this activation, they become silent killers. Why? Because when those cells receive this signal, there is activation of a big complex called NRF3 inflammasome that is cleaving inside the cell's molecules that are executing cell death process, particularly pyroptosis, that has been demonstrated in the retina. So this silent killer is killing what? It is killing number of cells that are involved in maintaining the barriers and also photoreceptor cells and ganglion cells. So in diabetic retinopathy, we know that years of metabolic dysfunction is going to lead to inflammation, oxidative stress, activation of this neuroinflammation, and then all cell types are suffering. And also the cells that are maintaining the barrier, not only the endothelial cells, but all the cells surrounding the pericytes, the macroglia, and the pericytes. So you see here that part of this phenomenon that leads to barrier breakdown is this microglial activation and neuroinflammation. In vein occlusion, you might think that it is very different because this is an acute event. There is a clot, and there was no something that was coming, it was here since years. But if you see who is getting vein occlusion, not everybody. And we look at the risk factors, it's lipid metabolism, allergic condition, hypertension, endothelial dysfunction, and there are also markers of inflammation in the blood of patients that are having brain occlusion. So probably they have a low-grade inflammation systemic that is favoring even the occurrence of the occlusion. And on the other hand, of course, there is a big mechanic factor here, which is the clot and the dilation of the vessels, and there is a vasogenic edema. But some patients, they are going to get very well, and some others are going to have edema, and even worse, ischemia. And why? Probably because this mechanism of restoration are not working well, and there is this neuroinflammation that is taking place. There have been a work showing that if you look at the mean blur rate at the optic nerve head in vein occlusion, and you compare it to the cytokines in the aqueous humor, the lowest is this rate, the higher are the level of inflammatory cytokines, but there is not a good correlation of VEGF. So there is a correlation between the flow velocity and the cytokines. Another observation, this is a paper from Rick Spade, it showed that when you have low flow in the deep capillary plexus, this is where you're going to have the edema. And this is because what is controlling the blood flow in the deep capillary plexus is the potassium around the vessels that is controlled by the Müller cells. It's the same cells that are responsible for fluid homeostasis. So if the Müller cell, so a glial cell, is dysfunctioning, then you have at the same time low blood flow and you have edema. And this is the glial Müller cell in a normal retina, and you see in the diabetic retina in humans, it's very, very changed, but you also have area where you have lost the cells. So this cell death is also affecting the potential of recovery. If we treat neuroinflammation, maybe we can preserve the retina functionally. Here we have restoration of anatomy, but unfortunately the vision is low. Why? Because there is disorganization of the layers and loss of photoreceptors. Not only there is disruption, but there is also hyperreflective foci. If you look here at this patient with RVO, you're going to see that the first event is a thickening of the outer retina, and this is not where vessels are located. It's where the Müller cells are pumping the water. So how can we detect this early neuroinflammation? Probably hyperreflective foci that correspond at least in part to glial cells, microglial cells that get activated. And how can you recognize that they are very pathogenic? Is because here we've seen this in histology, they are in the outer retina. And you can see here it in this case, if you have these microglial cells located deep in the retina, that's a very bad sign in terms of function. I want to share with you these images. This is a model where we have created an acute stress with irradiation. So it's just acute once. And you see that at 1 week, you don't have much change. But 1 month, 6 months, there is an ongoing neuroinflammation and macroglia, the Müller cells here in the down. And this is what is going to cause ischemia. It's going to kill the vessels because of the inflammation. At the level of the RPE, the same phenomenon is happening. There is increasing number of cells coming from the choroid, and it's ongoing silently and then leading to the complications. On OCT, what are the markers of neuroinflammation? In DME or in diabetic retinopathy, we have a number of signs such as the hyperreflective foci, but also disorganization of the layer, the thickness of the layers, and I think that Laurent is going to talk about that. When there is big edema, there is another phenomenon. There is infiltration of other type of cells that come from the circulation, monocytes, polynuclear cells. And here, just look at this slide with this number of cells around the cyst. After 5 injections of anti-VEGF, there is not much change. Of course, anti-VEGF are efficient, but they are not working on all these mechanisms. Corticosteroids, on the other hand, they are acting on all these neuroinflammation and pure inflammatory factors. And it has been shown that they work and they are more efficient than anti-VEGF in some of those signs, such as hard exudate, hyperreceptive foci, and subretinal fluid. And look at this patient, same patient. I switch him to Ozurdex, and after a month, it's finished. After 1 month, it has disappeared. So in summary, neuroinflammation, activation of microglia and macroglial cells, dysregulation of the Müller cells, leads to breakdown of the barrier, cell suffering and cell death, and then the real inflammation that is taking place and also should be treated. So now Laurent is going to tell us if we treat early, maybe we have the possibility to preserve the vision.
Thanks a lot. First of all, I would like to congratulate Anat Loewenstein, Barry Cooperman, and Patricia Udaondo for organizing such a fantastic congress, and to thank ABBVIE for this kind invitation. So you can see here my financial disclosures. So I would like to focus today on two key questions. Why treat earlier, and what are the biomarkers? Let's change the paradigm of treatment. The earlier, the better. On this Rise and Write study, you can see that duration of edema really matters, and it impacts vision. In the orange group, you have the sham group not receiving ranibizumab before 24 months, and when they received ranibizumab after 2 years, they gained some vision, but they did not reach anymore the level reached by the patients treated initially. On another study published 15 years ago, you can see that the longer the duration of DME, the more visual acuity decreases. And 10 years later, you have the same conclusion. So really, persistent of edema is an unfavorable prognostic factor for long-term visual acuity. And you have this observation in diabetic macular edema, but also in retinal vein occlusion. And you can see here that for patients with a short macular edema duration, visual acuity outcomes are better. And on the right part, you can see that if we have a delay to treat patients, each month we lose 10% of the chance of gaining an improvement of more than 15 letters. So we have to treat early. The second key question is about biomarkers to influence the prognosis and also treatment choice. What are the biological ones, the anatomical ones, and how can we use artificial intelligence? So about the biological biomarkers, we can see that increased concentration of several cytokines, interleukin-6, interleukin-8, MCP-1, for example, but also VEGF, are associated with diabetic macular edema versus healthy controls. But it's really important to remember that VEGF is not increased in the vitreous of all eye patients. And I said it more than 10 years ago, that could explain why 1/3 of our DME patients are not responding to anti-VEGF, because this VEGF level is not increased. And thanks to Patricia, I had the proof of evidence to say that now and to prove that. And we can see here that eyes with delayed or no response to anti-VEGF have lower mean aqueous VEGF levels logically. And 2 years later, another study published in an American journal showed the same key message that, for example, in this one, but it's the same key message, anatomical super and early responders versus slow responders and non-responders showed increased mean VEGF levels. But it's very important to note that anti-VEGF does not work against interleukin-6. It does not decrease this inflammatory cytokine. And on this study, you can see easily that the steroids can decrease all the inflammatory cytokines and also the VEGF. Look, the p-value is statistically significant, but with anti-VEGF on the other part, you have no any action about all the inflammatory these biomarkers, biological biomarkers, but of course you reduce VEGF with anti-VEGF. And now let's make the link between these biological biomarkers and anatomical biomarkers, because we have some anatomical biomarkers that may negatively influence visual acuity, like large retinal thickness fluctuation, low amount of residual tissue between plexiform layers, presence of drill or drawl, low capillary density, but also probably absence of serous retinal detachment and presence of hyperreflective foci. And we have different clues and proofs, and Francine just showed to us that these two OCT biomarkers are linked to inflammation. Serous retinal detachment has been reported as being associated with higher levels of inflammatory cytokines. We know that the hyperreflective foci correspond to activated retinal macroglial cell, and Stella Fijokovic made the link, so we know that. Here, a very rapid, because I do not have enough time to present, but these patients, you see, had two imaging biomarkers of inflammation. At baseline, the hyperreflective foci, the subretinal fluid. I decided to treat it by anti-VEGF. 1 month after the second dose of anti-VEGF, you can see an increase in retinal thickness, a decrease in visual acuity, -7 letters. So I decided to switch to Ozurdex. I had inflammatory biomarkers with very, very good results. You can see it. 1 month after the first Ozurdex, +8 letters. 2 months after the second Ozurdex, +13 letters. And now, thanks to artificial intelligence, we have a tool, an efficient tool to visualize, to quantify these inflammatory biomarkers. And you can see here in yellow, thanks to a software called COPHy, developed by Professor Midena. We can see here in yellow the hyperreflective foci. We can see Ardexudex in purple, in blue the subretinal fluid. And here you can see a patient I treated and it disappeared almost at month 2 after the DEX implant. And at month 4, you can see this recurrence. And here we can also monitor. You can see that at the recurrence, we had the same level at baseline for subretinal fluid or intraretinal fluid, for example, but not anymore for the hyperactive foci that not completely, but really disappeared. And so, for example, for this patient, we have to retreat it earlier. You see, like I said, I have to retreat it. We have to retreat it earlier, but we are going to speak about that with Thibaud and Anat. So, to sum up, early treatment initiation improves visual acuity and prevents worsening. OCT biomarkers like subretinal fluid, hyperreflective foci can act as surrogates for cytokine biomarkers of inflammation, and artificial intelligence analysis of biomarkers has the potential to revolutionize the diagnosis, assessment, and management of diabetic macular edema. Thank you for your attention.
These are amazing, this was amazing data presentation from both sides. And while Patricia comes up to the podium, I will ask the panelists a question to each of you and just a short answer. Fang, if you have hyperreflective foci, does it influence your decision to use steroids? Yeah, Lou, yeah.
Sorry. Yes, I think they are also the biomarkers for me to use corticosteroids.
Thibaud?
Yeah, sure. It is part of my algorithm, such as they have cataract or something like that. So this is a part of my algorithm.
So hyperreflective dots, space, dots, area will make you use steroids. Francine?
I think it's one of the biomarkers, so there are others, but of course it's an important aspect, particularly if there are a number of those cells and if they are located in the outer retina. I would suggest using steroids.
And we know what you think, but if you want to elaborate in one sentence.
Very rapidly, of course, we have to take it into account, but it's not the only factor. We have to take into account what treatment we are going to choose. Yes and no.
I just want to emphasize that sometimes the existence of hyperreflective foci just represents a very severe disease. So in the study that Dina Tzur, I don't know if she's here, did with the group of the young retina specialist that was organized by Allergan, even before it was ABBVIE, they showed that the patients that that don't have hyperreflective foci, they respond even better. But it was not comparing between steroids and anti-VEGF, just to show that sometimes it's very, very severe disease, and it might not respond to anything, but that all of the data shows that it does show that there is inflammation. Okay.
Now it's my pleasure to introduce Patricia Udaondo, that she will debate with Lu Fang from China and Patricia from Spain, of course. Should corticosteroids be considered as first-line therapy for DME and RVO? Yes and no.
Thank you, Laurent. So in this time, I have the yes position. So to me, it's the easy position because, as you know, I do use steroids, and let me just tell you the reasons why I think they should be considered as a first line, and also the reasons why you should consider steroids as first line. So my disclosures. So first, could you again scan the QR code to get your responses of this question? Should corticosteroids be considered as first-line therapy for DME and RVO associated with macular edema? Okay, then it's done. I have nothing to say. Good. No, 50%. No, it's changing. Good. We will have a nice debate, Fang. Good, you see? That's the reason why controversies are good, because there's not always 100% answer. Second, I'm not. Do we have to vote for the second? No. Okay, let's go. So I think I have two main reasons why I decide to use SOS as first line. First of all, the pathophysiology, even if we are dealing with different diseases, they all have a common complex pathophysiology. Second, the mechanism of action of steroids, and then the third, the clinical evidence that we already have, because we have been using steroids for many years now. So the evidence is consistent, and we have a very long follow-up with patients using steroids. So we first need to consider, among the complexity of the challenge of treating DME patients or RVO patients, that we have many factors influencing the treatment response. So we have the disease-specific, with the multifactorial pathophysiology that we will see in the next slides, the biomarkers that can reflect this complexity, and then the patient's factors, which is the lack of adherence or the specific conditions of the eye or the systemic conditions that are also important. So we are all familiar with how complicated the pathophysiology of macular edema it is. So it's not all about VEGF, ischemia, or non-perfusion. We also have inflammation since the beginning, and something very important that Francine pointed out previously, the neuroinflammation and the neuroprotection of the diabetics' eyes, that we know now that it's not a vascular disease, it's a neurovascular disease. RVO is the same. It's a multifactorial where we have together the inflammation, the ischemia or the non-perfusion, and the vascular leakage. And if we really need to control the disease, we need to take into account all these factors. It's completely different. It's a more acute, not so chronic at the beginning. We have hypoxia and this ischemic reaction, and then all the inflammation is coming up into the eye. And this is also shown when we measure the levels of the different inflammatory cytokines, either in the aqueous humor or in the vitreous, and we all are familiar with this kind of table. We can find many in the literature where we have high levels of VEGF, but also all these inflammatory cytokines that are the reason why some patients are not responding properly to anti-VEGF, and sometimes we need something else. And what happened with steroids? That they have also a multiple action that should work for a multifactorial disease, because we know that they are pleiotropic, so they reinforce the innate immune system and represses the adaptive immune system. So it makes that we have more chances to restore the homeostasis of the eye and to try to solve the vicious circle of the diseases. We also need to remember that we have different actions at different levels. So we have an effect on the junctions, which is very important for the barriers. We have the direct anti-inflammatory effects. We have some kind of anti-angiogenesis effect, and the neuroprotection, which is becoming more important in these last years. And what about the clinical evidence? So I think the highest level of evidence, because we are on a debate and we are on a controversies meeting, is the meta-analysis and the reviews. And let me show 3 different meta-analyses from the last 3 years, and they all have the same conclusions. So in terms of efficacy, when we compare the clinical trials and the results of the prospective studies, comparing DEX implants and anti-VEGF, the conclusions are always the same. DEX implant treatment is more effective in both improving the visual acuity and reducing the macular edema. And this is very important. And the most important, it is also in refractory and chronic patients. Regarding the safety, I'm sure the Fang will just talk a lot about that. We know that we have higher risk of elevated IOP compared to anti-VEGF, but in my hands, I think that we can easily recognize the side effects and to try to look for them and control it. So in conclusion, macular edema secondary to either diabetes or vein occlusion are multifactorial, where inflammation plays a very important role. But unfortunately, we have a steroid with multiple action to block these pro-inflammatory transcription factors, and we also have the neuroprotection and the protection of the barriers. So the scientific evidence shows this action in meta-analysis demonstrated the superiority in terms of controlling visual acuity and the disease with macular thickness. And we have the safety profiles that are not so in favor with steroid, but at least are manageable and well-known. Thank you very much.
Good afternoon, everyone. I'm Fang Lu from West China Hospital, Sichuan University. In this debate, my standpoint is corticosteroids should be reserved for second-line therapy for DME and RVO. So this is my financial disclosure. And as we go over with the guidelines and consensus recommendations for the treatment of DME, established by ICO and, let me see. Oh yeah, here, sorry. By ICO and European experts, Asian experts, and also AAO from the United States, they all recommended anti-VEGF as first-line treatment for central involving DME. Actually, so corticosteroids in first line only in some selected conditions, such as with high risk of cardiovascular disease, poor compliance, and severe macular edema, photosuchic eye, and so some patients scheduled to undergo cataract surgery or with a history of vitrectomy. And when we look at the anti-VEGF agents, including ranibizumab, aflibercept, and cambacept from China, they have been widely applied in DME and RVO over 10 years. We have plenty of RCTs and plenty of reliable data with both on safety and efficacy. So if you worry about the frequency of injection, the algorithm has actually switching from monthly injection to this PRA and TME. So according to the data of the phase 3 clinical trial, Yosemite, the mean number of injection of faricimab in 2 years is only 10, with comparable efficacy with those monthly injection of ranibizumab in DME, actually. And I do agree that with widespread use of anti-VEGF for the first-line treatment for DME, there are still 25 to 40% of patients doesn't really achieve optimal functional and structural response. The hypothesis is the patient experiences great inflammation. And studies do show that intraocular inflammations, inflammatory cytokines are upregulated in DME and RVO, not only VEGF, but also a bunch of others, actually. Yes, the thing is, how can we figure them out? How can we pick them up? And if there are possibilities that OCT allows the identification of inflammatory markers. So the database search was conducted to identify studies evaluating the association between inflammation and OCT biomarkers in DME and RVO. About 32 publications were selected. Unfortunately, there's no RCT, and the sample size are quite small. Only 9 of them has a bigger than 100 patients. And finally, go to the risk of side events. Because the steroid-induced glaucoma usually presents with few or even no symptoms. It is often diagnosed after significant damage has already occurred. That is why we have to avoid to use corticosteroids in patients with risk factors for steroid-induced ocular hypertension, such as suspected glaucoma, neovascular glaucoma, high myopia, and short trabecular meshwork hands. And yes, cataract. The thing is, real-world evidence reveals over 40% of the phakic eye require cataract surgery during the follow-up after dexamethasone implants. So that is why we have to consider about the balance between risk of cataract and corticosteroids effectiveness. And in conclusion, the current status of corticosteroids in diabetic retinopathy guidelines still remains the second line. And although some experts do agree in the first line use in some selected conditions, there is not lack of universal adoption. And for the treatment landscape for DME and RVO-ME, there are most of the anti-VEGF therapy is available for the treatments. Actually, for the next generation, like small molecule or high dosage, even multiple targets like faricimab, they can achieve the sustained efficacy with reduced treatment burden. For the challenge to identify the disease, last page. Currently, there's no validated biomarkers and standardized criteria, and also there's no large-scale RCTs confirming increased efficacy for corticosteroids versus anti-VEGF efficacy in this subgroup. And for this safety consideration, the corticosteroid-related complications require vigilant monitoring and present challenges. Thank you for your attention.
Thank you very much. We have about 6 minutes to discuss. Patricia, please sit. Patricia, first question for you. What is the profile of your ideal patient for first line for steroids, X implant?
Well, I think that the advantage is that we have options and we have many patients. So we have a variety of patients regarding DME and RVO. So to me, what you were saying, so when I see biomarkers of an aggressive disease, when you have big volumes, when you have subretinal fluid, when you have hyperreflective foci. So I think all those biomarkers that we all know that are directly related, not with inflammation, because inflammation is always in the retina. So ideally, all patients should have a benefit from steroids, but particularly, I think we should balance the status of the eye with the general conditions. So to me, biomarkers showing inflammation is the perfect profile to at least start with steroids. It doesn't mean that I cannot combine or change or do it something else.
Do you consider pseudophakia, like Fang said?
Not
really. What are the real barriers for you to use steroids in first line?
Actually, for those patients with very severe macular edema, huge mass of exudates, I would like to choose steroids. And there's an old Chinese saying that if you can't beat them, join them. So combination would maybe an option to, really good application for this kind of patient.
Do you consider compliance? We know that China is a very big country. Do you have any issue to see your patient regularly? Because with anti-VEGF, you are supposed to inject regularly your patient. So is it not an issue for you? Is it not a good argument to use steroids in first line?
The thing that depends, because during the pandemic, that is very, not uncommon, not easy for us to have this policy to have PRN or TNE, because patients usually forbidden to go outside to the clinic. And nowadays, because my hospital is the most popular, most famous hospital in China, and the patient has very good compliance with us. So I really don't worry about the compliance, the frequency of the follow-up. Actually, I'm just worried about the efficacy.
Maybe I can ask a question. Do we know if there are specific glaucoma, corticoid-induced glaucoma in patients, in Asian patients as compared to Caucasian? So do we have a difference in their response in terms of glaucoma?
So in my
frequency,
mind, in my mind, that the open-angle glaucoma is much popular than in China than in European, actually. So those patients with elevation of intraocular pressure after the administration of corticosteroids, we used 1 or 2 drops can control most of them, the majority of them. Actually, in my experience, I have never had a patient finally use the surgery to resolve this kind of problem.
We reported in literature that we don't have steroid-induced glaucoma with Ozurdex, with DEX implant, because the effect is transient. So it's really important to say, of course, we could have intraocular hypertension, and I agree with you, we succeeded to manage it with only drops in 97% of these hypertonic cases. We have one question from the audience. Is there a possibility that anti-VEGF for DME can temporarily mask proliferative changes? Patricia or Fang, do you want to comment?
I beg your pardon?
So the question is, do you think that anti-VEGF could mask the ischemia as a non-perfusion we can have in periphery, and so it would be a drawback?
You mean the anti-VEGF will manage all the inflammation?
No, would mask the ischemia in periphery, mask?
No.
Not really. Patricia, do you want to comment?
I think that with anti-VEGF, sometimes we have that cosmetic effect, just controlling the proliferation, but when you stop the treatment, then it reappears. So in the end, it's a different way of treatment. With steroid, we don't have such a direct effect in regressing the new vessels, but with steroids, we have evidence showing that we can control the non-progression of diabetic retinopathy. So I think that's also very important.
Thibaud?
Yes, actually, with the dexamethasone implant, it masks also the diabetic retinopathy. And we know in randomized control study that the GRSS score decreased under dexamethasone implant too. So for both anti-VEGF and dexamethasone implant, we have to be aware of this masking.
Last question, 1 minute, not more. Patricia, for you, I do agree with you that we can use DEX implant in first line, and I'm sure you agree also. Do you think that the new anti-VEGF will change the place of a DEX implant?
No, I think there's always a place, because in the end we have the same factors and the same problems. We do have to manage with VEGF in certain profile of patients, and then we have more inflammation and more aggressive cases that we still need the steroid. So no competition and combined therapy. As Fang was saying, why not?
The panelists, yes or no? Do you think that the new anti-VEGF will change the place of steroids?
No.
Yes, no? No.
No.
Thibaud?
As you say, some patients do not have VEGF increase in the eye, so for this case, we need the steroids and no anti-VEGF.
Question of class, so it's not changing much.
Okay. Thank you. So we go on. Thanks a lot. We go on with the third and last debate. Yes. So Anat versus Thibaud. Thibaud, it's finished for you.
No.
So
no.
we will see.
I got to be the underdog here.
So do we have to wait until 3D recurrence before retreating our patients?
Yeah. So I'm reminding you to scan the barcode, the QR code, to submit your responses. And I want to ask you guys, what do you think? Should physician wait until fluid recurrence before retreating patients? Namely, is the existence of a little bit of fluid really, really important? And we should wait. So my work here is done. No, it's not done. Okay. So my role is really complicated, as there is no exactly data to answer the question that I'm asking. And I went back, when I tried to build this, I went back to studies that looked at what happens to the patients that have a little bit of edema that was persistent if you need to go quickly and treat it, for example, with a steroid, if you didn't respond and there is just a little bit of edema, or you should wait until the edema recurs big time, and in many, maybe sometimes it doesn't. So there was the sub-analysis of protocol I that we did long time ago that showed that there was a very strong relationship between both the visual acuity, which you see on this slide, the visual acuity after 3 months, and the final visual acuity. Another study that was published in the same sub-analysis, and the first author was Professor Srinivas Sada from the United States, looked at the question if there is still fluid, still a little bit of edema in patients that after 12 weeks, what happened to them at the end of the day? And it showed this sub-analysis also for visual acuity and for persistent of edema, that, because it was protocol I, no patient was switched to anything. At the end of the day, it was really detrimental if you didn't go ahead and do whatever you could to treat the edema, but rather continued with the same regimen that was not as effective at that time. The final visual acuity was not that good. However, when we look back, it seems that the analysis was a little bit flawed in many ways, and of course, it wasn't able, because it was just a sub-analysis of protocol I, they just had the same treatment all the time for each arm. It was not able to actually tell us if switching is important or not important. And when we look at the mean change in visual acuity in patients in every group, so in the aflibercept group, patients that had more than 10-letter improvement, they continued to do well, as you can see after 2 years, and this was also true for the bevacizumab group and for the ranibizumab group. So patients just continued to improve on their groups. Now, when you look at protocol T, and this was done by a different group, it was actually done by the investigators of the DRCRNet themselves. When you look at the importance of the change from baseline to 2 years by OCT response at 12 weeks, namely, if this persistent edema is important. So you can see that when eyes had less than 10% response at 12 weeks, you can see that for each group, the final visual acuity was not as good as if they didn't have fluid. It was not a very big difference, sorry. And also, when you try to compare it, with eyes that had more than 20% response, there wasn't a big difference. So it seems that I have something in my favor, saying that it doesn't really matter if there is just a little bit of fluid, that you don't have to run and you absolutely need to treat it. And the multivariate analysis showed that both when you look from baseline to 2 weeks and you look at what is happening from 12 weeks to 2 years, if you look at the third line that looks at the central subfield thickness, it was not statistically significant as a predictor to the final visual acuity. So it's contrary to what we are used to think or say in DME, it's not really crucial to go and treat just a little bit of edema that exists. And move that fast. Can someone help me with the slide because it doesn't move? Okay, and also when we look at the percentage of patients that had DME, look at patients that had persistent edema at 12 weeks, at least 20% of them resolved at 24 weeks. Finally, I want to focus on the new drugs. So the new drugs, like faricimab, when you look at the proportion of patients that didn't have fluid, absence of intraretinal fluid up to week 56, if you look at almost every time point, and most important, wherever, all the time point, the faricimab treated eyes, especially the PTI group, had less IRF. However, in terms of visual acuity, there wasn't a significant difference. On the contrary, when you look at the change in best-corrected visual acuity from baseline, then you can see that there wasn't a difference. So while faricimab more effectively reduced central subfield thickness, meaning that you would think that it would cause a better improvement in visual acuity, at the end of the day, the visual acuity was the same in all groups. So just saying that maybe just a little bit of central subfield higher thickness doesn't make a big difference. So that's true about faricimab. And it's also true about aflibercept high dose, because if you look at the change in baseline central retinal thickness all through the time or at the end, you can see that the high dose group fared better than the other groups. So, but the visual acuity is practically the same in all groups. So just to summarize, it seems that if you still have a little bit of fluid, a little bit of increased central subfield thickness, it doesn't necessarily mean that the final visual acuity will be different. So maybe before we think of switching, before we think of making something different, maybe we can wait until we have a lot of fluid and not stable situation. Thank you.
So I have the privilege to defend my position on why clinicians should not wait until fluid recurrence before treating a patient with DME or RVO. So this is the regulatory sentences. Don't worry, I'm not a criminal. And my disclosure. So this is a clinical case of a 42-year-old gentleman, house painter with a type 1 diabetes, not well equilibrated because of his lifestyle, often away from his home. He was treated for the DME with anti-VEGF on a Q6 basis for 4 years, but he recently lost to follow-up 6 months ago and came back to my consultation for a second expertise. And as you see, at baseline, there is a DME recurrence with a decrease in visual acuity, and as he has already pseudophakic due to his type 1 diabetes, I proposed to him a dexamethasone implant. It works well because at 2 months, the DME decreased and the visual acuity increased, but the patient recurred after 4 months. And I proposed to him another dexamethasone implant, and as you see, the story is repeating because at 4 months, he recurred again and again. So the patient told me, great, doctor, you decreased the number of injections, but it seems that I am also here every 6 weeks. Actually, in 1 year, he had 7 visits and 4 reactive injections. And this is the right eye, but the left eye has the same disease. Yet, we showed in the pre-DME study that the pattern of recurrence in a patient with DME treated with dexamethasone implant followed the same way, starting with a strict anatomical recurrence, that is to say the presence of a small cyst within the retina, and followed by significant anatomical recurrence and functional recurrence, which is the decrease in visual acuity. But the question is, are these small cysts always recurred to a functional recurrence? And the answer is yes. For 88% of patients with small cysts, they always recurred to functional recurrence, so in decrease in visual acuity. And we know from study on anti-VEGF that the fluctuations in macular thickness are toxic for the retina. And greater are the fluctuations, poorer is the visual outcome. And we recently showed this on dexamethasone implant. And this is another case of a patient treated for DME with anti-VEGF because he had a history of glaucoma with combination therapy. And we treat the patient with a loading dose followed by the proactive treat and extend regimen, searching for dry retina to extend the interval between 2 injections. And this is a proactive treatment regimen. And we know that in a clinical trial, they're moving from PRN, so reactive regimen, to proactive regimen for anti-VEGF. And for dexamethasone implant, we reduce the delay between re-injections. And I will show you what I do in my clinical practice to reduce the retinal fluctuations in a patient with DME. And in this patient with DME, we see here the edema, and I check for the pattern of recurrence. Here, it is every 4 months. And when I have this pattern, I propose to the patient to inject him just before the recurrence to limit the fluctuations. And you see here, I see him at 3 months and a half. He had no recurrence, but I inject him like I do with anti-VEGF. So this is proactive. And if he had no fluid, I propose him to re-inject another time at 3 months and a half. So this is proactive regimen. And if you want to keep the retina safe, to limit fluctuation and increase the visual acuity of the patients, you have to do this treatment protocol. We have 2 therapeutic classes, but there is only 1 disease. So follow the same paradigm and vote yes.
Thank you very much, Thibaud. And thank you, Anat, of course. For me, it will be difficult to moderate because Thibaud belongs to my department. So, of course, I believe also that we have to use a proactive regimen also for DEX implant, but not only for DEX, also for anti-VEGF. So my first question for you, only the first one, I have others, is which regimen do you use when you use anti-VEGF? Not speaking about DEX implant, but anti-VEGF in DME patients, which regimen do you use? PRN or treat and extend or a fixed regimen?
So, in Israel, due to time constraints and resources constraints, we're using a kept PRN regimen or kept treat and extend. One of the two, and it really depends on the patient. Mostly kept treat and extend. So 3 injections, and then if everything is fine, we extend by 2 weeks, and then it comes 3 times every 6 weeks, and so forth. And, I was given this job of not treating, but I actually don't like to leave fluid, and I like to treat it. And in Israel, we always start with bevacizumab, and then for second line, I would usually go to other anti-VEGF agents, and then if there is no response, I'll go to a steroid. But sometimes there are patients like Patricia mentioned, and like in the first talks that have various reasons to go as second line to steroid, and sometimes also in specific indications as first line.
So we could say that you demonstrated to us that fluid doesn't really matter always, but nevertheless you do not tolerate fluid. Of course. But it's a very good question about this fluid tolerance, because in clinical practice, in daily practice, we do not tolerate fluid. Nevertheless, if you look at the new anti-VEGF in their pivotal studies, by using their retreatment criteria, they accepted subfluid to be tolerated. And nevertheless, at the end, they have really excellent outcomes. So it remains really a good question.
But maybe it depends which fluid also. Subretinal fluid or intraretinal fluid is not exactly the same.
So this was my second question. We know that in AMD patients, we know that subretinal and intraretinal fluid do not have the same prognosis. But today we speak, and you spoke about DME. Do you think it's the same in DME? Do you think there are different prognosis value of subretinal versus intraretinal?
Retinal in my discussion, because I think in DME and RVO it's mainly intraretinal. Of course, if there is overflow, there might be subretinal, but usually I focused on intraretinal. I think that for subretinal, the discussion is a little bit different, and it's more for AMD, more AMD related.
Thibaud, you spoke about proactive regimen. That means that you will begin to treat maybe dry patients with DEX implant. Of course, I agree, as I did like you. I do like you. Nevertheless, that means that you will inject more Ozurdex in 1 year in comparison to a reactive regimen. So are you worried about IOP, about cumulative risk of hypertension?
Actually, we published a paper on a PRODEX study analyzing the switch from the PRN to a proactive regimen, and we recruited almost 100 eyes, and in these eyes there is no alert on safety profile, but this study showed a significant visual gain when switching patients to this protocol. Since then, they are already treated with dexamethasone under PRN since 2 years. And despite these 2 years of treatment, we gain visual acuity when switching the patient to a treat and extend regimen.
Almost plus 4 letters. Francine, yes.
So with this regimen, do you succeed to extend more afterwards, or are you staying always the same?
Yes, not at the beginning. At the beginning, we stay at the same interval for 2 or 3. But in the second year, we showed that some patients can be extended.
We have 2 types of patients. Some patients can be extended, some no. But the goal could be to extend, But another goal, very important to understand, is we want to preserve visual acuity. And if each time we wait a huge recurrence before retreating, slowly and slowly, we are going to lose vision, to lose letters. And this is another goal we have to take into account. Anat, you yes,
sure. Two questions that came up. Protocol V says that patients with good visual acuity can be observed. This is completely true. If the visual acuity is perfect and the patient doesn't have symptoms, sometimes we observe. At least I do observe. I'm not, and actually I forgot to mention it. It could have helped me in my comments. Now, are the panelists considering severity of diabetic retinopathy when using an anti-VEGF or a steroid? Patricia, do you want to take it briefly?
Well, I think that very complex cases with a proliferative retinopathy together with macular edema deserve the combination treatment. In my hands, I do with everything: laser, anti-VEGF, and steroids.
Francine wanted to say something?
Yeah, I think that's a good option. There are a number of papers also in AMD now. They are combining with steroids. So it's coming back. So the patients that are very bad and not responding well, combination.
And finally, one anonymous commenter says that both drugs are complementary and we shouldn't spend so much time on debating which one is better. But that was not the point. The point was when everyone here on the panel agrees, the point was just to see if we can, when or where or at what time point to use each one of the drugs. Okay, so thank you very much for listening, and please scan the QR code just to help us improve for future events. And I think we had very good discussions and very good questions from the audience. So I would like to thank the audience very, very much. And now we have a 15-minute break, and then we come back to this room to the surgical session, and the other hall is also active during the next period. Thank you.